Ladies and gentlemen, after this very stimulating discussion, can you see my slides?
Yes, it is seen.
Yeah, it's seen, no?
Yeah.
Yes, yes.
Okay. Thank you. Yeah, okay. So the approach to aortic valve disease in the area of TAVI. Anything which is spoken to be abnormal, we need to see what is normal. Aortic valve has three important components, three cusps, three commissures, and three sinuses. It is supported by fibrous annulus. To show that these are the sinuses and these are the cusps which are closed, and these are commissures. Commissure is nothing but a gap between two leaflets when they are closed. And there is a node of Arrhenius, which is at the tip of the leaflet, and they allow the optimal coaptation of the leaflet so that there is no backflow in the diastole. The incidence or etiology of aortic stenosis below the age of 70 in Western countries is a bicuspid aortic valve congenital, whereas above the age of 70 it is degenerative, and rest of the conditions are inflammatory or degenerative or any other such cause. Very interesting data has been presented by Jayadeva Institute of Cardiology by Dr. Manjunath et al. The man is here with us. And the echo survey was done from 2010 to 2012. In that, 13,289 cases were found to be of valvular heart disease, and isolated AS incidence was 7.3%, which is third most common condition. Very interesting data from India. Now, the degenerative predominantly 65%, 35% bicuspid, and rheumatic is just 1%. Now, TAVI savvy people have come out with some extrapolated data from our census that about in our Indian population, 2% are above this age of 75, which comes to 27 million population. And incidence of severe AS is 3.4%, which is about 9 lakh cases. Out of that, symptomatic AS is 75%, and almost 7 lakhs cases are there. Out of that, 4 lakh cases are suitable for surgical AVR, and remaining 40% cases, about 3 lakh, are suitable for TAVI. So this is very interesting data coming up. And coming to the LVOT obstruction, it can occur at 3 levels. One is the supravalvular, valvular, and subvalvular. I'm going to cover today in my talk the valvular level aortic stenosis. The supravalvular and valvular, subvalvular and supravalvular are congenital. Subvalvular again divided into the hyperdynamic cardiomyopathy, which is HOCM that we know, and then there could be a fixed bridge below the aortic valve as a diaphragm or ridge. And supravalvular again are of 3 types. One is hourglass appearance, second is a diaphragm again, and third is a diffuse narrowing of the ascending aorta. Now, and valvular can be congenital plus acquired, that we have discussed. The typical pathology in bicuspid aortic valve, you can see that there is severe calcification, but valve can be unicuspid or quadricuspid. The only difference is unicuspid and quadricuspid will present little early than the bicuspid valve presentation. Whereas rheumatic, you can see there is no commissure seen because there is a commissural fusion. There's a typical pathology that we see in aortic stenosis, whereas in degenerative, you can see the commissures are intact. Now, coming to the natural history, the symptoms develop only when aortic valve size reduced to 1/3 of its normal size. So most these patients of bicuspid aortic valve will present in 5th or 6th decade with the symptoms, whereas degenerative one will present in 7th or 8th decade with symptoms. The reason being the gradient progresses at the rate of 6 to 10 millimeters of He per year. And the disease can aggressively increase if there are risk factors like age of more than 70, presence of hyperlipidemia, CAD, and chronic renal failure. Classically, the natural history, if the gradient is more than 25, the 20% patient only go for surgery or some intervention after 15 years. The classical symptoms are triad of angina, the life expectancy is 5 years, syncope, life expectancy is 3 years, and dyspnea on exertion, life expectancy is 2 years. The other symptoms can be sudden cardiac death or pre-syncope or fatigue. Coming to the pathophysiology, in normal person, the cardiac output increases with exercise, whereas in patient with aortic stenosis, severe aortic stenosis, cardiac output hardly increases. So BP falls, coronary ischemia worsens, myocardium fails, and cardiac arrhythmia develop. This happens with the exercise. So basic pathophysiology is of a pressure overload leading to concentric LVH, non-compliant LV, which increases LV EDP. LV mass is increased, and increase in myocardial oxygen demand, and that leads to myocardial ischemia and heart failure. The atrial fibrillation is extremely poorly tolerated, understandably so, because of the loss of atrial kick. So severe aortic stenosis is defined as 1 centimeter or less than that, equal to 1 centimeter or less than that. And critical is less than 0.7 centimeter square. Whereas when you want to interface it with the body surface area, it is 0.5 centimeter square per meter square. The hemodynamic hallmark is the gradient in severe aortic stenosis. The peak gradient can be 50 to 100, even more than that. And this is the main pathophysiology of the aortic stenosis. The clinical finding, the physical presentation, physical finding depends on severity of the AS. If it is mild, then cardiac pulse, the carotid pulse can be normal. In moderate, it's slow rising, whereas in severe, it's Parvus and Titus both, and slow rising and slow peaking. Whereas in apical impulse will be normal in mild, heaving in moderate, and heaving plus sustained in severe one. The S4 gallop is not heard, best heard in severe, and it can form a double apical impulse. One is of the LV and apex, another one is of the S4 palpable. The ejection systolic click is often heard initially in mild cases and sometimes in moderate cases because the valve is pliable. When the valve becomes immobile in severe aortic stenosis, ejection click is not audible. Coming to systemic ejection systolic murmur, it is early peaking in the mild one, mid systolic peaking in the moderate, and late systolic peaking in the severe AS. And it is typical diamond-shaped murmur, crescendo, decrescendo, and S2 can be single in mild. It may be single or just a mild split in single second heart sound, or mild split in normal, or single second heart sound in moderate. And in severe, it is usually single or paradoxical. Just to show you that the pulse rises so slowly that anacrotic notch, which coincides with the aortic valve opening, is seen very well, along with the dicrotic notch, which is also seen normally, which coincides with the aortic valve closure. To show you how if you want to appreciate the paradoxical split, it has to be in the expiration when the P2 occurs early and A2 occurs late. There you can appreciate other heart sounds and murmur I have already spoken about. Classically, the ECG shows LV strain with LVH. X-rays, there is unremarkable except for ascending aortic dilatation can be seen in severe aortic stenosis. So mainly the echo has revolutionized the diagnosis and management of the aortic valve disease in toto, and more than 95% cases are sent for surgery only by evaluation by echo. But only caveat is the operator, the echo operator has to be a very experienced one, because there are several pitfalls. If you don't do it properly, you can make a serious mistake. So first is peak systolic, peak systolic velocity. Velocity is measured by continuous wave Doppler signal being put across the aortic valve just after the aortic valve, and you can see the jet velocity as 5.4 meter per second in severe. Anything above 4 meter per second is severe. This is 5, so this is very severe aortic stenosis. And even when there are no symptoms, these patients are advised to go for AVR right away, because the event rates are very high if they are left alone. The gradient, mean gradient, can be obtained by tracing the Doppler envelope. And velocities wise, if we want to assess the severity of aortic stenosis, severe is, as I said, 4 meters per second, and very critical is 5 meters per second. Moderate is 3 to 9. Coming to the mean gradient, severe is equal to or more than 40, and 20 to 39 moderate, and less than 20 is mild. Coming to aortic valve area evaluation, initially it was Bernoulli equation, now it is continuity equation based on the hydrodynamic principle which is used during the Gorlin formulas. The same principle is used here, that whatever volume is there in the LVOT will be transmitted into the aorta across the aortic valve. So based on this principle, the hydrodynamic engineering principle, this is the aortic valve's area is defined, and it comes out to be very close to invasive evaluation of the aortic valve area. And critical is 0.7 centimeter square, and severe is less than 1, and 1 to 1.5 is moderate. Now, sometimes the evaluation by the continuity equation may be doubtful because of the change in the stroke volume. It can alter the area, so you can make error. To eliminate error, Doppler velocity index has been used, which is, if it is in normal, it is 1. In patient with severe or critical severe aortic stenosis, 0.25 less than that is suggestive of severe or critical aortic stenosis. Now, there are 4 subgroups of severe aortic stenosis that can be observed in clinical practice: high grade, high gradient, high velocity, normal EF. No problem. If you have a symptom and all other criteria of severe AS is fitting, this patient will go for AVR, class 1 indication. Low gradient, low velocity, and low EF. If this is low, then we need to evaluate by further testing. Another is paradoxical. EF is normal, but flow is low gradient, and that we need to discuss. And asymptomatic severe AS requires different intervention. So first we discuss the low flow, low gradient aortic stenosis with a low ejection fraction. This can be evaluated by dobutamine stress echo to study the flow reserve. If stroke volume increases by 20%, mean gradient increases or equal to more than 40, and aortic valve area less than 1 is suggestive of true severe aortic stenosis, should go for AVR if it's symptomatic. And if the stroke volume increases 20%, but the mean gradient is not above 40, the aortic valve area is more than 1, then this is perhaps pseudo severe aortic stenosis, goes for medical treatment. When the stroke volume doesn't rise, the DSC is indeterminate. In that case, we try to study the calcium score with MDCT. Calcium score of more than 1200 in women and more than 2000 in men is very likely to be a severe aortic stenosis. It should be sent for surgical or catheter area. Wherever there is a doubt about the evaluation by echo, we can say study this patient by CT scan or CMR. The another variety is low flow, low gradient, but normal EF. So that can happen with the pronounced concentric remodeling. So the LV volume is very low. LV cavity becomes very small. Mitral regurgitation, the oral stroke, oral volume coming to the LV is less because part of it is going into the into the left atrium. Same thing will happen with the tricuspid regurgitation. Mitral stenosis again is responsible for low flow, low gradient. How do we assess this? These patients are usually predominantly female patient, elderly, and their valve area, if you assess by echo, is less than 1 centimeter square. They have a concentric LVH and loss of compliance and reduced stroke volume. They may have associated hypertension. These patients do not do well on medical treatment, so AVR is supposed to be a better treatment for them. Now, asymptomatic patient, because they modify their own activity, they can be asymptomatic despite having severe aortic stenosis, should be subjected with the low risk to the stress test. If symptoms are reproduced on the stress test, these patients again will go for AVR. Now, if the patients are younger, and particularly congenital aortic stenosis and predominant commissural fusion, we can do a balloon atrial valvuloplasty in certain subsets of patients, particularly those patients who have heart failure or extremely high risk for the AVR. They can be, palliated by doing the AV. Then Ross procedure is indicated in younger patient, but requires similar size of aortic and pulmonic root, and then autotransplant of the pulmonary valve into the aortic position and reimplantation of a coronary and homograft in the pulmonary position can do the valve. The only therapy that benefit these patients with aortic stenosis is the AVR. And 99% patients survive more than 5 years, 82% more than 15 years. And but there is a problem here that the surgical risk may be very high due to high STS score in almost 40 to 60% patients of severe aortic stenosis, and they are now considered for TAVI procedure. So STS of less than 4, no doubt surgical AVR, 4 to 8 surgical AVR still class 1, but some patient can go for a TAVI and depending on the heart team discussion. But if you have a prohibitive risk for surgery, surgical AVR, or extreme risk, these patients will go for TAVI. 2 TAVI valves which are very popular at the moment, the core valve and the sapien valve, being used all over the world. But India also has a MY valve, which is also very popular in India and also in European countries. Now, new algorithm has been proposed by ACC, AHA, and ESC for the management of aortic valve disease, particularly in the era of TAVI. If there is low risk, no problem, surgical AVR class 1. If intermediate risk, depending on the STS score, still surgical AVR class 1 and TAVR class 2, but this is left to heart team discussion. Whereas high surgical risk, the surgical AVR and TAVR both become class 1, and prohibitive risk, TAVI is class 1 indication. Now, this is the part of the aortic stenosis. Coming to aortic regurgitation, the epidemiology of the aortic pure aortic regurgitation, predominantly valvular aortic regurgitation in main is seen in 3/4 of the times it is in the main, except in rheumatic, along with the mitral valve disease, AR is also very common, particularly in women. The chronic AR often presents late in the age of 50, and prevalence severity of AR is with the age it increases. However, there are many exceptions to this observation. Patient with bicuspid aortic valve and Marfan, they can present early in the life with the AR. So AR can be primary valve disease. AR can be due to primary valve disease or primary root disease. Primary valve disease, same conditions that cause AS will cause AR also, whereas primary root disease is commonly seen due to Marfan disease, aortic dissection, senile aortic ectasia, and long-standing hypertension can lead to. So, but in the natural history of chronic AR, relatively these patients remain asymptomatic for almost up to the age of 15 years. Palpitation is a predominant symptom, particularly on lying down on left side. And sinus tachycardia on exertion is very uncomfortable complaint. It may be associated with head pounding. These complaints may persist for many years before exertional dyspnea develops. And once the exertional dyspnea develops, these patients deteriorate very fast. They develop orthopnea, PND, and excessive diaphoresis. In the natural history, angina is commonly seen in this patient in absence of CAD. That angina can occur at rest and during exertion. And nocturnal angina is particularly troublesome in aortic regurgitation, and it is accompanied by severe diaphoresis. The anginal episodes are prolonged, often do not respond to sublingual nitroglycerin. Congestive heart failure develop and sudden cardiac death is a possibility. At rest, the cardiac output can be up to 25 liters per minute in patient with severe AR, and particularly the chronic AR. And then LVEDP will rise as the volume will rise. So there is a classical relationship between the volume and the rise in LVEDP. The pathophysiology is with this volume, the EF still remains normal or maybe increased until the Frank-Starling law is surpassed. Limits of Frank-Starling law is surpassed. Once Frank-Starling law curve is surpassed, this patient can have a deterioration in EF. The end systolic volume rises. They become very sensitive to progressive myocardial dysfunction, and they deteriorate very, very fast. Severity of AR is dependent on the diastolic valve area, diastolic pressure gradient between the aorta and left ventricle, and duration of the diastole. Eventually, left ventricular failure sets in because of the myocardial ischemia, subendocardial myocardial ischemia, and necrosis, apoptosis develop. Severe chronic AR patients have largest end diastolic volume, and there will be cardiomegaly that is classically described as cor bovinum. Grossly, LV gradually transform into from an elliptical size to typical spherical configuration. The decrease in diastolic pressure and reduces the coronary perfusion, and increase in the end diastolic pressure increases wall tension. So there is increase in oxygen demand and decrease in oxygen supply that leads to myocardial ischemia. LVEDP rises. These patients deteriorate very fast. Coming to physical examination, they have classical water hammer pulse, bounding pulses, white pulse pressure, hyperdynamic apex weight. Thrill can be felt in the parasternal area if it is valvular, and if it is aortic due to aortic dilatation, thrill may be on the right side of the sternum. The early hollow diastolic murmur starts soon after the A2, and the length of the murmur correlates very well with the severity of AR, not the intensity of the murmur or thrill present. The murmur may be musical at times. When it is cooing murmur of idiom, then it signifies eversion or perforation of aortic cusp. The diastolic murmur of AR, when present in the left axilla, it is called a Cole-Cecil murmur. As I said, the regurgitation, if it is from the primary valvular disease, then diastolic murmur is best heard in third and fourth intercostal space, while the patient leaning forward at the end of the expiration. Whereas if the murmur is best heard on the right side, when there is predominantly AR is due to aortic root dilatation, and this sign is called as Harvey sign. Then functional systolic murmur due to large flow going across the aortic valve can be heard, And Austin Flint murmur is heard due to regurgitant jet hitting the mitral valve and causing functional mitral stenosis, which produces MDM, typically called as Austin Flint murmur. The A2 is normal or accentuated in AR caused by disease of the aortic root, but it is soft if it is valvular AR. P2 may be off-square due to early diastolic murmur present right after the A2, and S2 may be absent or single, exhibit narrow, or even paradoxical splitting can be heard like we hear it in the aortic stenosis. Now, auscultatory finding, as I said, ejection sound can be heard due to distension of the aorta, large volume of blood being ejected into the causing distension of the aorta. The surge sound indicates that there is a left ventricular failure starting, and it's a bad sign for patients of AR. Indicates severe AR. Even per se AR, large volume AR can cause S3. The auscultatory feature of AR are intensified by strenuous and sustained hand grip, which augments the systemic vascular resistance. Then peripheral signs, several peripheral signs are mentioned, but typically water hammer pulse, head bobbing. Hill sign is no longer considered as sign of severe AR, because now it is considered as a sphygmomanotic measurement error or artifact. Durosus sign at the femoral level or Durosus murmur can be heard. Then there are several other signs like Muller sign, Corrigan sign of dancing carotid, and pistol shot sounds may be heard at the aortic area. When pulse is Bispherians, then AR is associated with AS. Then this pulse, Bispherians pulse, is best felt in the brachial or femoral artery, not in the carotid. The heart failure develops. As the heart failure develops, the pulse pressure becomes either normal or it becomes low in congestive heart failure with AR. Or other causes of associated aortic stenosis, mitral stenosis, and of course, systemic hypertension can cause low pulse pressure or normal pulse pressure. Severity of AR depends upon profound marked peripheral sign, large LV enlargement, apex is down and out, S3 is there, long duration of diastolic murmur, Austin Flint murmur present, LVH is there, and radiological cardiomegaly. Now, this condition AS and AR may be associated in a given patient. So clinical finding of AS will be noted in patients who have predominant lesion as AS along with AR. And if they have predominant AR, then predominant signs of AR will be noted. ECG is typically volume overload pattern, which is Q wave in V4, V5, V6 with upright T wave or even prominent T waves. In this patient, you can see the inverted U wave. This may occur due to left anterior descending artery ischemia in the territory of left anterior ischemia in the left anti-LAD territory. The X-ray is typically left heart border, left ventricle is seen. Left heart border is like an enlarged left ventricle. Ascending aortic shadow may be seen on the right side. So again, echo evaluation is typically done on this patient, and no cardiac cath required unless you need to look at the coronary. Even coronary can be looked at with the CT scan. Normal coronary, the positive predictive value is almost 95%. So echo, if it shows Austin Flint murmur, can be correlated with presence of flutter on the AML, which is classically seen in patients with AR, jet hitting the AML, and color Doppler can show you whether this is mild or moderate. Then there are certain indirect criteria or semi-quantitative assessment on echo. One is width of the vena contracta at the minimal area, the narrowest end we should measure. If it is more than 6 millimeter, then it's severe AR, moderate 3 to 6 millimeter. But these are semi-quantitative. Pressure half time can also help. If it is less than 200, then it is suggestive of a severe AR, 200 to 500 moderate, and less more than 500, it's mild. But when we there are quantitative assessment also possible on echo of the AR, but for that we need we need to measure regurgitation gate width upon LVOT diameter. If it is more than 65%, it's severe, moderate 25 to 65%. Similarly, jet area upon LVOT, with this formula, we can derive a significance of the aortic stenosis, and severe will have more than 60% ratio. The effective regurgitant orifice area can be measured easily on the echo, and if the width is less than 0.3%, indicates severe aortic stenosis. Moderate is 0.29 to 0.29 centimeters square. Then presence of hollow diastolic reversal of descending thoracic abdominal aorta suggestive of severe AR. Once the diagnosis of severe AR is made based on the various clinical and investigative criteria, we can decide on whether this patient needs AVR or not. If patient is symptomatic, AVR class 1 indication. If patient, if symptoms are equivocal, we can subject them to stress test. If symptoms are reproduced, then class 1 indication for AVR. No symptoms reproduced, then we look at the LV function. If it is less than 50%, again class 1 indication for AVR. Whereas if normal EF, we look at the end systolic dimension predominantly. If it is more than 55, again class 2A indication for AR. If it is between 50 to 55, class 2B indication for AVR. But if it is less than 50 end systolic dimension, then this patient can be subjected to periodic evaluation by clinical evaluation or by echo evaluation. Various valves, the mechanical and the bioprosthetic valves are available, which can give a very good result currently. And those patients who have aortic cause for AR, their valve can be spared, annuloplasty can be done surgically, and this patient can be recovered. If those patients who are not suitable for surgical intervention, they will go on the medical therapy. Classical medical therapy is S inhibitor, digoxin, diuretic, even ARB can be used, salt restriction, but beta blockers are classically contraindicated in these patients because it will prolong the diastole and that will increase the regurgitation. And avoid isometric exercises, and atrial fibrillation and bradycardia are very poorly tolerated by patients with AR. In-human studies are going on of TAVI being done, TAVI, possibility of TAVI in the severe AR. So all that we need is the size of the valve has to increase, and it has to hold because there is no much calcification. The valve has to hold in the position. So there is a definite the mechanism by which valve can hold on the surface of the, so something like struts in the stent may be put on the valve and that can hold the valve. That is being attempted and there is a partial success on that. So it's still under investigation and research. So prognosis is death occurs after the angina develops within 4 years and within 3 years if heart failure occurs. It is imperative to intervene this patient before irreversible LV dysfunction occurs. So going by LV end diastolic diameter less than 50, you should have very close follow-up with echo on this patient. As soon as it reaches the 50 or less than 50, close to 50, they should undergo for AVR. After the AVR, the long-term results reveal 80 to 90% 3-year survival and preserved with a preserved LV function, and poor LV function 40 to 60% 3-year survival. And mortality rate of the AVR is 3 to 8%. With this, I can summarize that aortic valve disease at the valvular area, valvular level, can be AS with AR, but this requires The echo has lately revolutionized the diagnosis and the management part, but totally non-invasive investigation without any cardiac care, this patient can be subjected to AVR. The earlier the diagnosis is made, life can be prolonged. With the AS, life can be a normal expectancy, but with AR, expectancy is definitely reduced despite the AVR. So that is the end of my talk. Thank you very much for your kind attention.